So I'll start us off. My name is Alex Combo, and I'm the app developer manager for East Africa at Medicafia. So as we start off, I'll just give a brief overview of the digital health superhighway so that we can understand the role of the HIE in interoperability. So at a high level, the HIE, also known as the digital health superhighway, is the digital backbone that allows the different health information systems to communicate with one another. So rather than having every system build direct connections to every other system, the HIE provides a common platform for exchanging information securely and consistently. So we've got different components working together to support this exchange. So on the left, I'll be just talking through some systems that we see here. So some in the middle and some on the left, and how they all work together. So the client registry helps identify and match individuals across systems, ensuring that information about the same person can be linked correctly. Got the health worker registry, which maintains a trusted source of information about healthcare workers. We also have the terminology service, which provides the standardized codes and definitions, so systems can interpret data in the same way. And you have got the shared healthcare record, which serves as a longitudinal repository of clinical information. So while the interoperability services now facilitate the secure movement of data between the participating systems. So for eCHIS, as one of the point of care systems, the HIE enables community health data to become part of the broader digital health ecosystem. So information collected at the community level can be linked to national registries, exchanged with the systems, and used to support continuity of care as clients move between community and facility settings. So the interoperability initiatives we'll be discussing today will build on these shared services and demonstrate how eCHIS is becoming a very integral participant in Kenya's national digital healthcare architecture. Next slide, please. So far what we have in eCHIS is a patient record identity reconciliation. So this has been rolled out across all 47 counties. So this is countrywide, enabling identification and linkage of over 2 million individuals through the National Client Registry. This is largely adults. The community health concepts have also been published to the National Terminology Service. So all the HMISs that connect to the SHR and eCHIS can be able to share data and understand each other. We also got the Community Health Worker Registry that's been integrated. So this contains information about the community health units, the community health workers linked to those community health units, and also all the facilities linked to those community health units. And then finally, which is the backbone here, in the meat of this is the digital referrals, which has been piloted in 2 counties, and we've got over 2,000 referrals that have been exchanged so far with facilities. So here I'd like to invite my colleague, Irene, to just take us through what we have so far, which is. Thank you.
Hi, everyone. My name is Irene Bui, and I work at Medic as an app developer. I'll be taking you through a typical referral from eCHIS to the facility. Next slide, please. So generally, a referral would start with a community health promoter doing a house visit and providing a service. Depends on which service that is being provided, maybe an assessment, maybe immunization, and other workflows that might have reason for referral. So once this CHP has visited a household and has identified a reason to refer a client to a facility, the referral is triggered when the CHP submits the service that they were providing. So once this report has been submitted, then the information is sent as an outbound to the mediator and other interop utilities. So in these utilities, we have the information being routed to the correct area where it's supposed to go. And the information is then, before getting to the facility, the information is transformed into a file request and then it is able to be pulled through the facility EMR. Once that information reaches the facility, the clinician confirms the arrival and updates the referral status. So it depends on whether the client actually arrived at the facility or not. So either way, the clinician will have to update the referral status with whether the client was able to get to the facility or not. So once a clinician does this confirmation, then there is an automatic notification of the referral outcome that is sent to eCHIS. And based on this referral outcome, then the CHP gets a task. So whether this person missed the referral, the CHP gets the appropriate task for a missed referral. And if they were able to receive services from the clinician, then they also get a task to them, allowing them to provide the recommended care from the clinician. And so after this, then it also depends on what the outcome is with the CHP. If the person needs to be referred once more, then they are referred again to the facility. And if not, then the CHP can continue with providing services as usual. Thank you. We can now get a demo from Fred of a referral.
I have Fred, a developer from Medic, and I'll be taking you through a demo of the referral workflow. So to begin with, we first have to register client. So this is so that you can get the client's unique identifier from the client registry, which will then be used to push those referral records to the SHR service, or the shared health record service. So I'm just going to first register a person. Just copy paste. The most important detail is the national ID, which is used to identify the client. So when you're fetching this person's data, you first have to provide a valid national ID, and then the client registry will give you now the unique identifier it uses internally, and that is then saved to eCHIS. So we submit, and then we sync. We should get a client registry ID. So now we can perform an assessment, and we'll say this person is sick and is exhibiting fever of more than 7 days, which should be a danger sign, and the CHP should refer this person to a facility. So we submit this form, should trigger the referral. Let's sync once more. And then now we can go to the HMIS, we refresh, and we can search for the person we just registered using the national ID. Confirm. So from the HMIS side, they require you to have the person's consent to view their data. So in this case, since this is a UAT environment, we can bypass that by just inputting our own phone number. It's not showing, but the referral should show. Let me try another patient. So in the case of this is a client we had tested with before. So in the case of a successful one, it should show the patient referral and the place you had referred them to, the facility, the reason for referral. In this case was still fever, and yeah, you can see it from the HMIS side. I think that's the whole flow. Does anyone have a question up to that point?
I have a question. Who operates this interface? Like, who is the user here that you are impersonating?
A clinician at a facility.
Okay, so how does the clinician know that they have? So suppose that there's a new patient. So because right now you needed to confirm that this patient exists, right?
Yeah.
So what happens if the patient doesn't exist? So somebody goes into the village and enters somebody's number, and how does the clinician know that somebody has to be registered? Or if somebody isn't registered, do they just get lost along the way? Does the referral get lost?
So maybe we can step back to eCHIS. So on eCHIS, if you don't have a valid national ID, then that workflow won't work. You have to have like a valid national ID. And from the HMIS side, you have to show up the facility to so that the clinician can know that you are referred by eCHIS. There's no way, to my knowledge, for them to know beforehand that you are going in there because you are referred from eCHIS.
I see. So this step that happened at the facility happens when the client goes, when the patient actually goes to the facility to get their referral completed.
Yeah.
And they share their number with the clinician, and then they go through these steps.
Yeah.
Okay, that clears it up a lot. Thank you. So the clinician doesn't actually know beforehand that he will receive referrals that day. Like, they don't have a predefined list of referrals unless people show up.
No, they don't.
Okay.
Yeah.
Thank you. Thank you very much. I have another question. It says here covered. What does covered mean? And what is uncovered?
These insurance, like health insurance types. Yeah.
What happens if the person is not covered? So for example, the person goes to the facility and they are not covered by insurance, and then the clinician can't do the follow-up. Is there like a feedback loop where the clinician refuses to do the follow-up for some reason? Or does it go into the missed referral workflow?
So at the bottom of the page, you can select the cash. There's a select payment method, and I see there's a cash option. So I'm assuming they can just use cash in that case. Yeah, I'm also not like very familiar with this HMIS.
That's okay. So the if in case here in this UI, you can only register a successful referral. You can't register a failed referral, where the client showed up and the referral didn't happen. It will go into the workflow of a missed referral for the CHW.
I'm not sure I understand that question. Like a failed referral, like what do you mean by a failed referral?
By a failed referral, I mean that the person is not covered, for example, or they don't have cash, or something happens. There is no there is some resource. It doesn't necessarily mean that there is a malintent here, but I'm just curious if the referral system only sends successes instead of sending failures as well.
Maybe Alex has something to add. Alex?
Yeah, thanks. So I think I can add some color to that. So if we could just go back to insurance. So the insurance that's shown down there for the social health authority is the national scheme. And we do have an integration for that on eCHIS via the beneficiary management system. So we can pull that with the same client registry ID that identifies as the person within the HIE, and you can tell whether they're covered or not. So up there, we have the three schemes, UHC, PHC, and I think critical illness is one. So I think people who are registered on social health authority, but are not, they haven't contributed up to like the current month, are still eligible for one of the schemes. So going to a facility does not mean that you'll be turned away, and you will still get service. If you have a valid referral, it will still be addressed. Payment can be done by any other insurance scheme, cash, or even the ones under smart applications with still other insurance services. So it only transitions to a failed referral if one, the patient did not go to the facility. So we have a time period within which the referral is valid. Outside of that window, then it is termed as a missed referral, and on each they get the referral follow-up. If the person did make it to the facility, but then the encounter wasn't tied to that referral, maybe they went for something else when the referral was for another thing, then that also would be termed as a missed referral. So the referral here will only be complete if the patient made it to the health facility, the clinician tied the encounter to that referral, and it was completed at that point. I hope that clears it up.
Yes, it does. Thank you so much for the clarification, Combo. Can we see the referral task? The missed referral or the confirmed referral task?
Yeah, we can see for like a previous client. So in this case, we had a referral like initiated from the facility to the CHP. So I've done this before. So it will show the name of the person, the facility, and the clinician, and also the date of the visit. And if the clinician had some notes, they should show up. So in this case, I just wrote follow-up. And then it says the person available, and if they're available, if they discussed the notes that have been passed by the clinician. So this is for a referral that has been, so the client went to the facility, the clinician saw them, and then they refer them back to the CHP. So that's the like closed loop. Yeah. I'm not sure if that's what you're asking.
Yes, that's exactly what I was asking. This is great. Thank you.
Yeah, I guess I'll hand it back to Combo.
Thanks, Fred. Other than that, if there are no other questions, then I think we can proceed from there. Yes, so inviting Joseph Murage, so he's from AfyaReach, one of the implementers we have on the ground. He'll be talking about the experience that they've had in the counties he's worked with. Welcome, Murage.
So, hello everyone. My name is Joseph Murage. As mentioned, I work with an organization called AfyaReach, which is an implementing partner in Kenya, supporting digital health system strengthening in community health settings. So I've really worked closely with the medic team to implement these referral workflows in our county of implementation, which is Kirinyaga County. We supported the pilot of this integration, and majorly our focus was mostly with the integration happening digitally in the back end. Then we need to have the frontline health workers, at least for community health promoters, is sensitizing them that these referrals that you've been generating using the system, that is eCHIS, can be able to be linked to a facility EMRs, and the facilities, the clinicians at the facility, they can be able to receive these referrals and manage them in a particular manner. So we did the sensitization of community health promoters. We trained community healthcare workers at the link facilities, and also the community at large, at least to sensitize them on the importance of this particular piece of work. So with this kind of pilot program was actually very well received in the county of implementation, and there was a lot of positive engagement from both CHPs and the healthcare workers. But going to the challenges that we're experiencing while we were carrying out this pilot is that we had like a limited visibility of the generated referral within the ecosystem. That is that when a referral goes out in a live environment, a CHP has generated a referral, has sent that assessment service form and synced their form. So when we were doing the validation, we couldn't actually identify where we are getting the bottlenecks, because at the end of the day, remember, sometimes digital systems in one way or another, there might be downtime, there might be some issues here and there. So we could particularly identify where we are getting that bottleneck. The other challenge is the changes in the Kenya health ecosystem. The image that Alex presented of the HIE, that HIE came much later. In Kenya, we usually say that community digitized before now we'll say the whole of the country when it comes to digital interventions within the healthcare ecosystem. So these changes brought about a difference in the facility registry codes. So we are having new codes that were introduced, and when you look at eCHIS, the mapping of the community health units to the facility that are linked to this community health unit, there is a mapping structure that is used, and there are some codes that are used that are existent, but these codes are existent in a registry that was being used previously. Currently, we have a new registry with new codes, and the lack of the one-to-one mapping of these different codes led to some of the bottlenecks that we're experiencing while we were implementing this workflow, such that a referral has been sent and it cannot get to the facility because maybe there's a mismatch of the codes. Then something else Alex mentioned, the client identity mismatches. Also with the changes in the digital ecosystem nationally in the country, there was the introduction of the client registry ID. And this client registry ID is a prerequisite for a client to have for them, you'd say, to enjoy this linkage, this integration between eCHIS and the facility EMRs. So those are some of the challenges that we experienced while we were implementing this pilot. Alex, you could go to the next slide. So some of the improvements that we identified and also recommended, and I believe this first one is something that Alex has been working on, is the implementation of a monitoring and feedback mechanism, whereby even from the eCHIS side, we can be able to have a visibility of all the outbound referrals from the community level. That we know that Murage was referred from this community unit. And is this referral, was it digitally sent? Did it get to the HIE? Has it been received within the SHR, so that at least from the community end, we can have that visibility. And in case it is a failure, then we can know where this failure is emanating from. Is it from each side, or is it a failure of the facility HMISs? Then also the other improvement that we recommended for this particular kind of workflow is to establish routine processes for updating facility master data and link facility codes to accommodate changes within the health system. That is exactly something that needs to happen, at least at community level, so that these new changes that have come up, we can be able to accommodate them within the community health ecosystem, so that at least we can reduce the number of failed digital referrals that we are generating at the community level. This is the same case as what we are trying to do even with the client identity mismatches, such that at community level, we've been able to sensitize, particularly in this county of implementation, Kirinyaga County, and also nationally. We are seeing more and more clients within the community health ecosystem that have been registered on eCHIS, at least their details being corrected, and we are having that match in the details that is between eCHIS and the client registry, which is a major, you'd call it a major step for identification of any client within the health ecosystem to get services in our country right now. So thanks, that has been my presentation, and also the feel of what we got while we were implementing this particular workflow in Kirinyaga County. Back to you, Alex.
Thank you very much, Murage. I don't have anything else to add. I think that has been a great presentation by everyone before me. So thanks. Back to you, Diana, or the Jones.
Thank you, everyone. Such a great presentation. And as you were on the previous slide and you mentioned the bottlenecks, I was curious exactly how you were intending to address them. And I don't know, Combo, if you have any preliminary work done into the put into this monitoring and feedback mechanisms. I'm curious on what you were planning to use. But if there's no design yet, that's fine.
We don't have anything special right now. So we're still going very naive, biased, aggressively logging everything, just so that we have at least visibility of everything that flows through HIS. Now, the challenge lies on the other side. Once it goes out of HIS into the HIE, that's where things get a little bit blurry. Right now, the HIE is still very much being treated. It's a national system, so access to it is mediated, and we have to jump through hoops just to get access into the systems. So whenever the SHR is down, we wouldn't know. Whenever a HMIS is down, we wouldn't know. Whenever any of these other systems have a problem, we wouldn't know. So we're trying as much as possible to collect as much information as we can from our side. And then whenever we identify any inconsistencies, that's when we reach out and get to close the loop with the other participants of the HIE.
Thank you so much, Combo. Like I feel like whenever you have so many systems that and this nascent interoperability workflow, there's a little bit of fragility where everything needs to work perfectly. And yeah, I'm wondering if you were planning to do kind of like an apdex of referrals to see what percentage of referrals actually make it successfully. Not that they actually make it successfully as completed referrals, but in terms of the communication between systems. Do you have an overall number of how many referrals make it successfully through the round trip and how many fail?
The 2000 number that I presented earlier, the one that we could verify that they actually did make it to SHR, but we don't have a clue whether it was actually a completed referral or not. And now completed now being the person that made it the facility or not. But the work that we've been doing over the past couple of weeks is now getting access to the records now from the SHR so that we could now tie the loop. All the referrals that we've been able to send out to the system should be able to complete them, whether the people made it or not. Then, as part of this pilot that we'll be doing for the 2 counties, we could now give a definitive now report of, and this referrals that we processed over this number of months, these are the number that was successfully posted to the HIE. These are the number that we had patients make it to the facility. These are the number that we had referrals back to the community. And these are the ones that had a successful termination at the facility. Yeah, so that's still very much in the works.
Thank you so much for the info combo and excellent presentation, everyone. Thank you very much.